I think we'll get started. My name is Janice Keefe. I'm the director of the Nova Scotia Center on Aging and chair of the Family Studies and Gerontology Department at Mount Saint Vincent University, and want to welcome you to this webinar where we'll look at some of those complexities of implementing a family visitation program. I also wanted to introduce to you Cheryl DeVoe, who is CEO of the Cove Nursing Home. So great to have you with me, Cheryl. Thanks for joining us. And I'm going to go ahead.
No, thank you as well, Jen.
I'm going to look forward to your comments towards the end. Cheryl's going to give a bit of a reflection on what it's like to, from her perspective as an administrator, on some of the findings that we'll be sharing with you, but also about involvement in research and working with researchers. So here's hoping some of you who are on the line may be interested in that as well. So today I'm going to talk just a brief overview of the kinds of research we've done at the university, at the Nova Scotia Center on Aging, what we did in this particular study that looked at an implementation science approach to family visitation, and then the findings will be presented. We'll talk about the staff perspective first on the implementation process, the family perspective, and then we will look at the key informants that we interviewed internationally in this area. And finally, we will look at the impact of the visitation program on residents, family, and staff. Then we'll get insights from Cheryl, which would be most welcome. And then we'll wrap up with the key takeaways and next steps. And so look forward to having you ask questions. And please look for that. You can always send Paula a message if you're having difficulty. She's on the line and she'll be able to help support you. So just before we get started, I'd like to ask if you could fill out who you are, who's attending the webinar this afternoon. So I see we have quite a few from long-term care, less so from government, and some of my colleagues were planning to be here, but that's okay. So just have to click on where you are, what kind of position that you have. That's great. Thank you. So we have lots of long-term care administrators and managers and staff. So you're the very people we want to have on here. So thanks so much. The next question is, where are you from? Sorry, I guess you don't see the results. I'm there. I guess you see them now. So we have an 80% response rate, and we have most people, 40%, from the administration manager or other staff, another 30%. So that's wonderful. And where are you from? 65% from Nova Scotia, a good contingent from PEI, and a few from elsewhere. So thank you. Great. So we've been doing research at the Nova Scotia Center on Aging in the area of long-term care for quite a while, over a decade now. And we had started with the Care and Construction Project, which was a partnership with colleagues at Northwood, where we looked at the physical design of nursing homes and also the staffing models of care. It was just around the time that we were building new buildings in Nova Scotia. We wanted to see the impact of that on the resident quality of life. We later then looked at who seeks advice from whom when it comes to clinical outcomes, and found some really different interesting findings just in our own region between PEI, New Brunswick, and Nova Scotia. And so PEI, there were two main networks. One was more the manors or government-run facilities versus the private facilities. In New Brunswick, it was far more likely to be jurisdictional around regions of who talked to who. And then in Nova Scotia, there was a large provider, for-profit provider, and then there were a lot of other smaller networks. So really interesting stuff, especially when you think about how we spread innovation and best practices across our sector. Most recently, we just finishing up a project on a team project that was national in scope called SALTY, or Seniors Adding Life to Years, really looking at different ways of understanding the quality of life for residents in long-term care. And so we're just wrapping up that with a number of papers that we're publishing in the area of policies, in the area of burdensome symptoms at the end of a person's life, as well as evaluation of palliative care methods. So come to 2020 and COVID-19, we've been ramping up, of course, some of the challenges and history in long-term care the last couple of years. And this project is about that family visitation program, the policy and how it was implemented. We also have been doing some work for the Healthcare Association, or sorry, Healthcare Excellence Canada on best practices to support family presence and communication in the sector. And there's actually a webinar the 29th of November that HEC is putting on, that where we'll share some of our findings as well. If you're interested, just get in touch with us. And finally, we're working with the Nova Scotia Association of Nursing Homes to look at mental health and resiliency for the long-term care staff. So all of those are ongoing right now, as well as we are in about 10 facilities in Nova Scotia where we're looking at the quality of work life. So perspective of staff in terms of their levels of mental health, depression, burnout, resilience, supportive environment, and so on. And in the future, we're hoping to link up with our RAI resident assessment tool with some of that staff quality of work life and with resident quality of life, so that we can really get a handle on some of the outcomes for the residents when we're able to improve staff morale. So lots going on, but focusing on this study, we had 6 sites, 2 in PEI in Nova Scotia. Just wanted to show you this. There variety of sizes from a 36 bed facility to 120. Variations on traditional versus that household model or neighborhood model. Also variations on ownership, be it government, not-for-profit, or for-profit, and also in terms of who was responsible for leading the implementation and what types of staff were involved. So what we're sharing with you today are from these particular sites. So in terms of what we collected from the sites, we did surveys of understanding the whole scope of that facility, each of the facilities. We also collected policy documents, 108 in total, from the facilities as well as the health authorities around policies around family visitation, or that would affect family visitation. We then did 10 key informant interviews with people from British Columbia, the United Kingdom, and the Netherlands, to help understand, to put what we were finding in Nova Scotia and PEI in context with these other groups. We've done amazing amount of interviews, thankfully, for our staff and our wonderful graduate students. So within this very short time frame between March and August, we did 138 interviews, and you can see there how they were spread out. We interviewed both the person in terms of family, and by family, it's who was viewed from the residents' perspective as their family. So we had the designated caregiver or partner in care, depending whether you're in Nova Scotia or Prince Edward Island. And then we interviewed 15 of the non-designated individuals or caregivers. 32 implementation staff, 22 direct care staff. And then we did a follow-up at a time 2 in July and August. And most of those were with participants who had already participated in time 1, but we did add on 4 new interviews. So they would be family members whose individual was came into the facility during the COVID period or during the family visitation period. So that's sort of the background of what I'm going to present. So the findings from our work, we have sort of 5 different sections. I'm going to share the first 2, which is from the perspective of the staff. Gotta get my clicker going the right way. So what we found was that there was very much a top-down process, that the directives were externally driven by the provincial government. And although the facilities and the staff supported this family member visitation, there was limited evidence on the best way to implement the directive. So absolutely no guidance on how to implement, just the rules and regulations. And so staff talked about the fact that oftentimes it would be, there were so many changes to the program, the changes weren't always clear, nor there was very little flexibility. And so the directives limited the way in which they could actually mitigate or adjust the policy to fit their particular home. Certainly time constraints made it difficult to engage direct care staffs and family in the implementation process. Some mentioned they would have liked to include families as they've done in past programs, but there was just not possible given the time constraints. You know, that of course the time lag was a huge factor, and we heard that internationally as well. The long-term care facilities would learn about them as they were being announced to the public. So staff were unable to implement the change in a way that was safe and quick enough, and the families would come in and they'd often have a different interpretation from the media announcement than what was given to the staff. So there was always this idea of catch up that was being played on. Next, there was a lot of complexity around implementing the directive, a real sense of how you balance keeping the residents safe, having enough PPE available, the public health protocols as well, while trying to be flexible of when and how families could visit. It was definitely an advantage when the residents could be flexible by adjusting the staff roles to cover new responsibilities. So there were lots of different models here in terms of how people or who people engaged in some of the new activities. Some homes had administrators or managers implement some of the directives. In other cases, it was the recreation department. Sometimes those staffing pre-existing pre-COVID staffing shortages made it really difficult to implement the program. But a lot of people in Nova Scotia in particular spoke about the long-term care assistants who were hired to do the screenings, and they became the superstar of the program. So that was because of the additional government funding that really enabled some facilities to access these new personnel. So there was lots of other issues that came out around the space that was available and the number of visitors that made, again, some of the issues, the implementation issues very complex for facilities. So in terms of some of the enablers and the barriers to implementation from the perspective of staff, certainly the what we found was organizational culture was most commonly discussed. When you had positive staff, those staff being open and positive, that willing to pivot, go above and beyond, and having that support from upper management really made things move a lot more smoothly. And that staff buy-in was really critical to the implementation. And most staff were very excited for the program and to have it on board. There was most of the time there was good communication processes, straightforward, excellent communication was described, lots of team meetings. Communication was viewed as an enabler, especially from the upper management. You know, being able to take tasks, have time for question and answers. And sometimes in some cases, health authority were involved as well with questions and answers. Communication was also a barrier, though, and it seemed to be the lack of communication in some cases from the management to staff and to the direct caregivers, designated caregivers or partners in care. It wasn't clear always. There wasn't enough updates on all the different changes that was happening. And so then it became a bit of a ripple effect, because if the staff was confused, then they possibly gave the families misinformation, and then they ended up having to have negative interactions where they had to correct families about some of the rules that weren't being followed when there was some challenges in conveying those rules. So that's the staff implementation. What do we hear from the key informant interviews? Well, there's lots of similarities, and the center thing is really where there are similarities between what we heard internationally and what we heard locally. Lockdown, decrease in well-being, all the regulars, use of email and newsletters as communication tools. One of the things that we found most striking, that everybody had this issue with time to make the changes with announcements, that sort of balance as well. We also found some unique things that happened. For instance, in the Netherlands, at the beginning of the lockdown, the Dutch ministry actually gave each facility a mental health team with a social worker and a psychologist to help provide some support with the staff and the residents. Imagine that being available in Nova Scotia and PEI. We don't have enough mental health for our regular mental health. Anyway, that was quite a take home for us as researchers. We often also found that there was evidence-based decisions. So they have what we call a living lab in 25 different regions in the Netherlands. And so they were able to test out the use of PPE and sanitation and hand hygiene, and how if that, by those combinations, they actually could open up to other family visitors. And so there was no difference between the homes who had a complete lockdown and the homes that were more open with these extra events or precautions taking place. There was no difference in the amount or the number or the presence of COVID in those facilities. So the pilot really demonstrated that it's safe to have visitation when there's appropriate PPE and hygiene measures are taken. They also had a broader, perhaps, communication personnel, so that they had a number of videos that were created and available on their website. What we saw was different, or at least they hadn't talked about it, was in Nova Scotia, and I know in PEI that the facilities were able to go a little bit over budget, I believe, in terms of hiring other staff. But in Nova Scotia, we had some direct funding for these long-term care assistants. So those are some of the comparisons with our international key informants. So next I'll go to what the family's experiences were. So we've got the staff, we got some of the international. So what were the family's experiences? So interestingly, you know, the families were so grateful. They were locked out for 3 or 4 months. All they could do was express appreciation for the program. And even when the implementation process caused frustration, as they weren't consulted, they did not want to complain. They, you know, I've done, and this quote really gets at it. I would have done anything they said or asked just so I could be there with my husband. So this gratitude was really a reflection of being locked out for so long. You know, so they weren't going to complain. Certainly in one site, when they started offering virtual meetings, that became really important. And being able to ask questions and get some feedback was also really fabulous. So this was a practice that could be considered a promising practice to help with that, accommodate that meaningful consultation with families. So there was some training that was also provided at that time. They'd often compare what was happening now to the pre-COVID time. And in that cases, the visits were sometimes described as too rigid, awkward, uncomfortable. They themselves as family had no time to visit with the staff. There was no recreation anymore and no socials. So these sort of restrictions were painful for some, and they perceived that there was then no joy in long-term care anymore. So you know, and the quote here, you know, is really representing the concern that there's no joy at the facility. In terms of some of the enablers and barriers, communication was key. It was viewed as both positive and negative. You know, email, virtual meetings, the use of Facebook, all considered very positive, but it wasn't a substitute for staff who were to be available and to be able to communicate with family and answer their questions or provide support or guidance. It wasn't in terms of the non-designated families or non-personal partners in care, they seem to experience more barriers than enablers in terms of the communication and the use of technology. And we think that's because they're not the primary recipient of the email. They had to often rely on the designated caregivers for information. And so there was some of that because of weaker ties with the resident and the facility, the non-designated caregivers or partners in care were a little bit left out. So then finally, what was the impact on families and on residents? So, I mean, you already know this, that there were several families that commented on the impact of the closure on the residents' mental health and well-being. Residents stopped communicating as much as they used to. They seemed depressed cognitively, they declined, and they stopped eating as much. So, you know, as this individual was talking about her brother and saw a horrible decline, he was so sad, and that was just not him. And so post the visitation, this seemed to improve the residents' mood, alertness, communication, perhaps their appetite or even their ability to eat because of the family's assistance. So we have a lovely quote from one of the participant family members who says his eyes light up, he has a twinkle. When she first returned, she said it was like a ghost. His personality has returned and his mood is much better. So there has been these positives on the residents. And what about the family? Well, we know that the impact of family and resident was actually often coded together. What was good for the resident was also good for the family's well-being. So there's a real emphasis on mutuality here. Families felt better just knowing that the resident was okay, or that they could now actively help and visit with the resident. Families were relieved to be able to see and hear and touch the residents and have that sense of what was going on in the facility. So there was some sort of resumption of this sense of routine and normality, or the family roles that they had played, because the family visitation program was put in place. There were others, the families of residents with dementia commented on their appreciation that they could spend precious time with their loved one when the resident could still remember them. And as one daughter had suggested, if the participant was locked out any longer, it might have meant that she would have lost her mother completely, so that she would not have been able to recognize her if it had gone on much longer. So what about the implication or impact of the family program on staff? There was a lot of very positive outcomes. Staff were happy to see the residents happy. It was hard to see them so upset prior to the family visitation programs. In addition, family does provide that instrumental and emotional support. They often assist meal times, they provide one-on-one time with the resident, and it allows the staff to spend more time with residents who don't have visitors. So staff talked about having to take on the role of family during the lockdown, and now feel that that burden has eased somewhat. There's often as well the additional workload challenges have been mentioned. The implementation staff in particular mentioned that the program had added a lot of work for people who were the implementing of the programmer, the recreations, the long-term care assistants, etc. They had to do the calls, the screening, find places for visit, and in addition, there was responsibilities for housekeeping and laundry for sanitization. So as well, they found it difficult to have to monitor the adherence, monitor the families in terms of what when they were not breaking, that they wouldn't be breaking the rules, and also managing their expectations was another critical issue. So so here's a quote, I just got to go to the end. The work goes a lot smoother when no one is in, but it's much better for the residents to have families. So there's that dichotomy, I think, that's happening. And this is of course of families who had residents who actually came into the facility, and then the families were locked out and weren't able to visit for 3 or 4 months. And so in this case, this administrator talked about having a family council in person in August of 2020, and the fact that, you know, having that face-to-face enabled the family members to see them as humans and not just an institution. And so I love this quote, because the administrator said, people who started that meeting wanted to put me on a crucifix, who left with a hug, not a real hug because it wasn't safe, but a virtual hug. So that really showed that need for, I think, communication and the challenges, especially for families of residents who went in during the pandemic. Oh, that was, can we come big? Okay. So finally, I just want to talk a little bit about equity, diversity, and inclusion. As you know, we don't have a lot of racial diversity in our region or in our long-term care facilities, at least, but there are some. But we do know that there are some differences and inclusivities that we wanted to highlight that were shared with us from the staff and the families. First of all, the way that the program implementation affected residents with dementia, and whether, you know, program protocols should be modified to accommodate their unique experiences. Like some of the rules are very hard to follow for people with advanced dementia, difficulty not to wander. They're required to stay in their own room. They didn't recognize their families with the mask on, or even be able to see their lips move, or see them smile. That were all challenges. In addition, there were large families found it difficult to decide on who the 1 to 3 designated caregivers would be. So how do you decide out of 5 children and a spouse who will be that person? And several family members also said they were used to coming as a group. So 2 or 3 of them would come and have a conversation with the resident. So these one-on-one visits were out of the norm for them, and they found it difficult. This designation as well was often gendered. So we heard from males who were non-designated caregivers that, you know, it was their sister or the daughter that would be the best person to be the designated caregivers because of those gendered expectations on caregiving. Some families struggled with the technology, as I've mentioned before, or they live in rural areas. They have limited access to Wi-Fi. Not everyone has a computer or an iPad in their own home. And so these may have been limited for persons of lower income, for example. Some of the pre-existing relationships with family and staff often led to unequal implementation. They perceived that some families knew how to work around the system, that they were able to get exemptions about the family visitation because they knew who to talk to. So this was a concern that some had more of an in with administration than others. And then finally, and really importantly, family members' work schedule or the proximity to the facility was a barrier. They often struggled with the limited or rigid visiting hours that they couldn't get to during the hours of visitation when they were being offered in some of the facilities. So those are some of our key highlights. Look forward if you have a question for you to put those in the chat. In the meanwhile, I'm going to put them in the chat or the question and answer. I think there's another place for question and answer. Meanwhile, I'm going to pass it along to Cheryl DeVoe to give us her insights or her perspective as an administrator of the Cove Guest Home. Over to you, Cheryl.
Thanks, Janice. Hello, everyone. I'm happy to be here today. And as I'm listening to Janice go through the findings, you know, it brings me back to that March 15th, 2020, when we were directed to close our doors to all of the visitors. And you know, the emotions and the fears and the anxiety and everything that went with it that day and several days afterwards into the months just continued to build and build. And it was, as an administrator, and I'm talking just on behalf of the Cove Guest Home, and our perspective during the restrictions, and then when there was an easement and what did that look like. It was difficult. It was difficult. My heart broke for families. Also, staff were fearful that, you know, a family member would inadvertently bring in COVID into the building. But I'll be very honest. Over the term when the families and designated caregivers were asked to remain outside of our buildings, I always kind of thought about, I couldn't understand the parallel between families who I felt would be the last people who would knowingly bring in any danger into the facility, and staff going in and out, going home, coming in, and there was no vaccine at the time. So, of course, frustration on families' side, you could certainly understand that. PPE at the beginning was in so short supply that I was securing PPE from very unconventional ways. Wasn't in the black market, but I wasn't too far from it. In the lines of being able to get PPE for the facility. Staff were getting doctor slips to stay away from work. That was further impacting a bad situation. So it was to try to come up with a happy balance, or as happy as we could make it, between for our residents, which were our priority, staff and families. So it was, you know, certainly very confusing that our directives from Department of Health usually arrived on Friday afternoon at 3 o'clock. And we were expected to put in almost immediately the new guidelines, which were changed just from the day before. So again, it would set a pattern within the facility. Staff were becoming very anxious and very angry because things were changing so quickly. And but as an administrator, I was compelled to follow the terms and the guidance of public health and Department of Health. And for many of you who wouldn't be aware, we were further impacted, every long-term care facility, that most, if not all, of our insurance providers dropped us for any contagion coverage, which therefore caused a lot more anxiety within the facility. So this opportunity to participate when Janice had called, I was really anxious, but I was anxious to participate, but anxious to see the results. And I can tell you, I'm not one bit surprised with the results. It's something that I know, as if I was a family member, how I know I would feel to be excluded from my mother or father's care. Some did have their families die without, even though we always had exceptions for palliative, sometimes people pass away quite quickly. So I will say that there was a lot of sadness during the time where the families weren't in at all. We need families. Families are part of our circle of care. And for the residents, we could see them decompensating almost every day. They were lonely. The staff did not. We were running on very low staffing a lot of days. Staff didn't have the time to spend with them like families would come in and spend with them. So the socialization went down. Recreation wasn't available. Recreation were busy doing the screening or virtual visits with families. And a lot of our families, our residents who had dementia, couldn't understand this concept that we were putting a tablet in front of them, and they were reaching out for the screen, seeing what they believed to be their loved one, but not understanding. So that in itself, and even the window visits were difficult. The window visits were difficult in March and April when it's still quite cold out. And then bundling up families and loved ones to go outside. So I think this is the first time for all of us to go through the pandemic. And as somebody had said once, we were building and flying the plane at the same time. And, you know, did we do a great job? I think we did the best that we could. Under the given circumstances. Do I think we could do better? Always. And I think it's research such as this that shows us, as one of the most key things that Janice, everything that you said has meaning, but one thing that you did say today was the difference between those communities that still allowed families to come in. There was no greater risk of COVID coming, or there was no cases of COVID. So there is there is much to learn from this research. It's very important. That's one of the opportunities that I think government should look at. You know, when the next one comes along, which they say will come along sooner than this one. It won't be 100 years. But what are some of the things, I just wrote a few notes down here that I can tell you. I felt that the healthcare itself became more collaborative, not in the initial days, but as we got deeper into the pandemic. And communication was the key here. I was committed to sending letters every week to my families with regards to what was going on, what was new. And from one week to the next, I was sending them a different letter with different directives. So I'm sure, I know the day that they allowed us to open our doors to designated caregivers was one of the happiest days for me and for staff. And I know for our designated caregivers, but most of all for our residents. That's who we're here for. So with that, if there's any questions, I'd be happy to answer them.
Great, thanks so much, Cheryl. We're gonna we do have a couple of questions in the question and answer. I'm just gonna wrap up, and then we're gonna open it for people to ask questions and to respond to some of the questions that have been posed. But if you do have questions for Cheryl, if you have similar experiences, you have different experiences, it would be really helpful for us to know. It's wonderful to have, you know, 30 plus people from the sector on the webinar, and it's you also have your own insights and experiences that we will definitely value your insights and your input. I just want to take a few takeaways from ours. You know, as was said by Cheryl, you know, we may not have been perfect, but we were building and flying the plane at the same time. And so one of the key takeaways really was that families weren't considered. They were viewed as add-ons, and the real lack of recognition of the vital role that they play. So, but that wasn't just us. That was all over the world. They weren't consulted or involved in the implementation. And we heard from some providers that, you know, having one blanket approach for a whole province is probably not the best practice, because there's a lot of differences across provinces, across regions, even in outbreaks. And so providers would like to see more flexibility built into that visitation, so that community circumstances can help to dictate visits rather than provincial approach. A lot of staff told us, and I think this is a positive, that we now have a blueprint around this family visitation that can be used in future outbreaks that Cheryl has just mentioned. And, you know, really just to reinforce that vital role that families play in long-term care. I know we have a couple of folks from the National Standards of Long-Term Care on the call as well. And I feel like some of the value in this kind of research is helping to shape, you know, the value of that, what we call the designated support person. We're moving away from the language of family in the national standards, because residents are the persons who need to choose who they want to be their support persons. And so that the important value of including those people close to the resident to ensure that they have a continued quality of life is really, really important. And balancing that with safety, of course, always, but not without, you know, real recognition of that vital role of families and volunteers. Certainly we're continuing our research where we're going from here on some best practices with the healthcare Excellence Canada. So if you're interested, there's a webinar on what are some of the key best practices that we found across Canada, and we'll have some of our best practice administrators come and share with you the kinds of things that they did. And that's on, I believe it's November 29th. We also will have our outcomes of our quality of work life project, where we'll have some of the staffing outcomes in terms of their mental health and well-being and resilience. And we hope in the future that we can do more research around linking the inter-eye data with this sort of staff quality of work life, as well as resident quality of life. So we're hoping to move this forward for sure. And so thank you very much for your attention. I'm looking forward. I know that Louise Clemens had a question if we had the opportunity to interview public health office teams, and I think that was a really good question, because there was that, I think, disconnect between public health, who were dealing with a lot, and the understanding of what happens in long-term care. We did invite them to the presentation. I don't know if anyone from the government group that are here are from the public health, but we felt it would be valuable for them to also hear some of these data, but we didn't interview them. We have another question from Mary Brackenick from New Brunswick, and on the Long-Term Care National Standards Council, who asks us, were there any safe time concerns regarding infection control and visitors? So I'm not 100% sure if you're meaning whether or not they had, safety concerns. Okay, thank you. Of course, the whole safety thing trumped everything at the beginning of the pandemic. So that's why everyone was locked out, because, this idea that we had to stop the spread, and this was the most vulnerable population, and let's be honest, they also were the least funded and had been for many years. So the circumstance of long-term care, I don't want to get on a soapbox, but the circumstance that people in long-term care, administrators, staff, and residents and families found themselves in is really a reflection of decades of underfunding and undervaluing of what happens in long-term care. And so, I just think it's really important that we do learn some lessons from this for the next time that governments put more emphasis and energy into appropriate staffing models, appropriate training, recognition of the quality of life of the residents. So yes, I think safety was a big concern. I think a lot of homes address that differently. People had training sessions for family members on how, best practices around hygiene and masks, and so there were those training events. Some of those happened over Zoom as well, and so there was that ongoing sort of need to keep to make sure that everyone was aware of how to be safe when you were in the facility. But I think I don't know that the safety, I guess that's the biggest issue that we are now grappling with, I think, is how much does safety trump everything? And certainly during a pandemic, it's very easy for us to say, oh, we should have been open more, been open earlier, but I think we were in an uncertain situation. But I'm going to stop here, and if others have, or Cheryl, you have a comment that you want to make, I'm happy to pass the baton.
Yeah, one thing I think is that you touched on that really needs to go forward. We need to rebrand long-term care. It needs to be rebranded into the specialty that it is, that it's not just the poor second cousin of acute care. So that is something that I always am pushing forward. You're right, we've been underfunded for years. There's things that I have asked for over and over and over again for funding and was always declined. I did receive them this year. So COVID certainly, you know, was not the cause of all of our problems in long-term care, but it's certainly helped to expose them in this province and right across the country.
Great. Yeah, no, I think you're absolutely right. Elaine, do you have Elaine is here. Elaine is another member of the National Standards. Any other questions or comments from the group? Great. Internet issues in the Digby area of Nova Scotia happens to all of us at some point. Well, that's great. I'm really glad that you were able to come. I know you're all very busy, so appreciate the time that you've taken to hear about our research. I'll just end by some acknowledgements. I just wanted to thank our wonderful research assistants that helped us. These are all graduate students in our program here, or former graduate students. And we had an advisory group of family members that also worked with us very closely. We have amazing administrators and partners who joined our team meetings, gave us advice, gave us feedback. And finally, the staff and the family who participated in the interviews is really wonderful. And of course, our funders, the Healthcare Excellence Canada. So thank you all for coming. Do stay in touch with us if you're interested in the November 29th presentation. Do be in touch with either myself or Paula Richardson, who would have been the person sending out the invitation, and we'll get you connected to that webinar as well. Thanks very much.